Our second speaker for this session is Dr. Anish Kirpalani. Dr. Kirpalani is a staff radiologist at St. Michael's Hospital in Toronto, where he's a director of the St. Michael's MRI Research Center. He's an assistant professor in the Department of Medical Imaging at the University of Toronto and an associate scientist at the Lekashin Knowledge Institute of St. Michael's Hospital. Dr. Kirpalani holds a BASc from the Engineering Sciences program at UFT and an MASc also from Biomedical Engineering at the University of Toronto, in addition to receiving his MD from McMaster University. He is the author of numerous publications in peer-reviewed journals and has rendered several invited lectures both nationally and internationally in the field of abdominal and cardiovascular MRI. His research interests at the Canadian Foundation of Innovation funded St. Michael's MRI Research Center is in validation with the MRI tools as quantitative outcome measures in high-impact abdominal and cardiovascular clinical problems. He is the imaging lead for a CIHR, NSERC, and PSI-funded research program in kidney fibrosis MRI. And please join me in welcoming Dr. Kirpalani to render this presentation.
Good morning, everyone. Thanks for inviting me here. Thanks, Vasu, and thank you to the IMS for inviting me to share a little bit about our research program with you this morning. You know, what I've learned about research is that you don't get anywhere without a great team. You don't get anywhere without great collaboration, and I'm fortunate to have a wonderful team around me, a truly multidisciplinary team, including my collaborators, Darren Yun, who's a nephrologist and a clinician scientist at St. Mike's, General Leung, who is a research MR physicist, Serge Jyoti from pathology at St. Mike's, and Justin Kim, an outstanding medical student here who's working with me, who's helped put together a lot of these slides in this presentation as well. So I think that's one of the first, unique things I think about our program is it's not unique in successful research programs, I think, to have great teams. We have more people working with us, including the following people who support our research program. And from a funding perspective, we've been fortunate to receive grant funding from these agencies, along with our hospital foundation and some industry partners as well. So just wanted to get all of that out of the way. So when we talk about high impact clinical problems, kidney failure and chronic kidney disease is among the highest impact things you can work on. It's not as well recognized as maybe some other disease entities, but about half of people who develop chronic kidney disease go on to die within 3 to 5 years. So this is a big problem, and it manifests in many different ways. Among those people who have chronic kidney disease, there are really only 2 treatments once they get to a significant level of kidney failure. One is dialysis, and the other, the kind of desired outcome among these people who wait for many years for this outcome is kidney transplantation. And kidney transplantation has revolutionized outcomes and results in people with chronic kidney disease, but the long-term outcomes, and you can imagine yourself waiting for a decade for a kidney transplant, and then within a few years of receiving that kidney transplant that changed your life, got you off of dialysis, did all these things, you develop chronic allograft injury, which about half of people develop within 10 years of receiving their kidney transplant, and their transplants fail and they go back on dialysis, or they need to be retransplanted, or they have other problems. So it's a devastating problem, and it's one that has received a little bit more attention recently. So what happens to these organs? Not unlike many other organs in the body, the chronic disease progression of kidney transplant failure and chronic allograft injury is driven by fibrosis. Fibrosis is a common problem in many different organs. It is the end pathway for virtually all causes and etiologies of kidney transplant failure, and it's the most important risk factor for the progression of kidney disease in people who have transplantation. You can see histologically the changes that occur in the kidney with interstitial fibrosis in between, vital cells and vital structures in the histology makeup of the kidney, glomerulosclerosis, and multiple other changes which occur in kidney fibrosis. So how do we measure kidney fibrosis today? Well, the best test that we have is a pretty flawed test, and that is a needle biopsy. It's performed by a radiologist like me. Percutaneous renal biopsies carries there are two really big problems with this test. First of all, it's invasive. We put, under ultrasound guidance, we put a needle through the skin into either a native kidney, as in this example, or into a kidney transplant. And this is an organ that people have been waiting for years for this, for this organ. They're not so excited about having a needle go into it and create a risk of bleeding and infection and other potential problems. So there's an invasiveness that people don't like. And there's another big problem, and that is we can only take a very tiny sample of an organ that is probably 10 to 12 centimeters large by 4 or 5 centimeters wide and has got a significant volume. We're only taking millimeter long cores of this organ from a specific part of the organ to be safe, and so we have a major problem with sampling bias. We can only get an idea of what's happening in a small core of a big organ, and if the process that we're looking for is not very uniformly distributed throughout that organ, we're not going to get a great sample. Yet this is the best way we have to assess kidney transplants and look for things like fibrosis and other things like inflammation. And we have pathology has a standardized way of looking at these organs as well on histology. So that's what we do today. Maybe tomorrow we might have a non-invasive way, maybe with MRI, of assessing these kidney transplant organs. Whereas biopsies are invasive, an imaging test like an MRI is non-invasive, whereas biopsies are time-consuming, including getting day admitted to the hospital, having recovery time. MRIs are relatively fast in comparison, and whereas with a biopsy you sample a very small part of an organ, MRI gives an organ-wide or kidney scale picture of what's going on in terms of the pathologic process that you're looking for. We know that fibrosis causes certain changes in the tissue, in kidney tissue that we are looking at. And we can try to relate some of those changes from a cellular level and what we know to what we may be able to test with MRI. MRI is an imaging test, but it has multiple different specific techniques that we might be able to tailor to the processes that are actually happening in this process of fibrosis. So what are some of those things? Well, we get an increase in the extracellular matrix in these organs. We know that we have a reduced, you can see here the amount of small blood vessels or capillaries in a normal kidney, and you can see the decreased capillary density when organs fibrose, and the increase, of course, in the extracellular matrix that you're seeing here as well. If we think about it in terms of the diffusion of oxygen into various tissues and cells in a fibrosed organ or in a fibrosed kidney, you can think that there will be an increased restriction to that diffusion of oxygen into various cells, and that may be something we can measure on MR. So thinking about those pathologic processes, what are the things in our MRI toolbox that we might be able to test in those kidneys? Well, one thing we can do is we can test the stiffness of an organ using a technique called MR elastography. And we know from other organs, specifically the liver, that increasing stiffness is seen and correlates well with increasing fibrosis. We can use various techniques to assess blood flow and perfusion to try to relate to the decreased capillary density that we see in fibrosed organs. And we can measure blood oxygenation using a specific technique of MR called BOLD imaging, which is often used in the brain. You may have heard of functional MR imaging. It's largely the same concept. And these are all techniques that we can use with MR, that we can fill our MR toolbox with to assess these kidneys. So does it work? So our initial work has been in looking at these MR techniques and looking at kidney transplants and seeing if we can find a difference. I'll just share with you, a particular patient here as an illustrative example of some of what we found. This is a patient who came to us at regular clinic visits at St. Mike's, who was 2 years post-transplant and was clinically doing very well, totally normal, good urine output, blood work was great, the patient was feeling fine. And we were able to get an MRI of this patient through a research protocol, and we were able to see that patient again about a year and a half later when they started to do not very well. Their blood work had become abnormal. They were clinically starting to show signs of failure, and the nephrologists were concerned about them to the point that they wanted to further investigate them. And so we were fortunate to get biopsies and MRIs at both of these snapshots in time in these patients, and we have other patients who are like this as well. But just as an illustrative example, you can see from a conventional MR image, this is just a grayscale MR, T2 weighted MR image, that really shows no big difference between these kidneys and the same kidney, same patient at two different points in time. However, you can see from an MR elastogram, which shows the difference in stiffness throughout this kidney. You can see on the left at the point when the patient was normal that though the distribution of stiffness is somewhat heterogeneous, the amount of stiffness as shown by more red color is far less than what it was a year and a bit later when the patient started to do bad clinically. Well, how does that relate to what we see in biopsy? Well, in biopsy on routine trichrome staining, at those same two time points, you can see the increase in the stain of fibrotic tissue in this kidney at the same time point when we saw an increase in stiffness. Similarly, we did a perfusion MR scan at the same time points as well, showing that there was significant loss of the microvasculature, presumably due to the decreased capillary density that we're seeing in patients who progress. And we know that their fibrosis scores on pathology had worsened in that time interval as well. And we know from some preliminary data that our stiffness measurements using MRI correlate with the fibrosis scores in a standardized way that are assessed at biopsy. And I think, the next steps are to look at not just pathology and not just histology and not just the presence of fibrosis, but the outcomes of these patients using various measures. How does MR relate or predict outcomes of these patients down the road? So that's just kind of a quick whirlwind of what we've done. Some of the projects that we're working on in our research program are technical optimization of MR elastography, one of the tools in our toolbox for assessment of kidneys as opposed to other organs. We're continuing to look at the relationship between stiffness measured on MR elastography with biopsy results in people who have abnormal kidney function. We're starting to look at using an MRI toolbox as a potentially predictive biomarker for renal outcomes and outcomes in patients who have kidney transplants. And we're starting to look at not just down the road in people who have kidney transplants, 1, 2, 3 years down the road, but we're looking in the acute post-transplant period while patients are still in hospital in the days following their transplantation and looking what MRI can tell us in those patients. So we have multiple different projects and multiple different studies going on as part of this program, and we're very excited about the potential for this program to give some more insight into the management, the treatment of patients, true clinical outcomes that we're looking for. So in summary, we've got a multidisciplinary research program that's grant-funded. We're studying the use of MR in impactful disease, particularly in kidney failure and kidney transplant health. And we have some promising data that we're moving forward with, and we're excited about what we potentially could find. Thanks.